So why are we worried about endoscopy? Is small, beautiful and better? Probably can we do it under functional spine surgery? This is the least approach related aortic damage and the most best vision you can get here. We have now for the past 5 to 8 years we are seeing consistently better results also with endoscopy. This is one slide. Please remember, in endoscopy, if this is your fascia and if this is your narrower part of the vision, you see better, you see clearer because the camera or your eye sort of goes inside and more closer to this thing. That is the difference between a scope and a microscope. This is the difference with stenoscope. Dr. Sai told you about the higher angulation. Here you have only about 10 to 15 degree angle. Working channels are different between different companies. Basically they are about 120 to 125 millimeters in length, and any working channel above 5.5 millimeter till 7 millimeter is okay. It depends on your money and your thing. In vivo visualization is even more difficult than transforaminal. Please do not think that this is easy. I will tell you why. In transforaminal surgeries, the scope is relatively fixed. If you have passed through the intertransverse membrane and your scope is into the disc, it doesn't shake much. Okay. So x-axis, y-axis, z-axis are there, rotation is there, and going in and out is only there. Whereas in interlaminar surgeries, you are holding the scope vertically and the scope also has translation movements. So there is one more angle of movement in interlaminar. It looks appealing, it looks easy, and it is a very routine procedure, you will think. But the left hand has to be controlling 3 movements: x, y, depth, rotation and translation, 5 movements. So that is the most challenging thing. The scope will be shaking around, okay, especially in stenosis. So after this is the difference with transforaminal and this thing between length, height, everything. Absolutely essential items our friend has talked. We will go to regarding anesthesia. Okay, so the same. If you have your anesthetist who is also doing obstetrician and gynecologist cases, you ask them for this same painless labor anesthesia, half concentration of ropivacaine, or not ropivacaine, this Sensorcaine they can give. If you want, you can give half concentration of ropivacaine also. Thereby you can easily have analgesia, no motor blockade, and if you manipulate the nerve, the patient will tell you pain. You still can do it. Now for the past 1.5 years, my anesthetist and me, we have modified it. We are doing even these cases under a modified spinal anesthesia, but that is the same functional spinal anesthesia, where we give hypobaric Sensorcaine mixed with a little bit of fentanyl and a bit of buprenorphine. BP stays flat at 100 and absolutely no pain at all. You can do easily 2-level decompressions comfortably under spinal. Why I changed to spinal is because putting in an epidural catheter and all these things take about 30 minutes for the anesthetist to do. That is why we have done this. But I would suggest you can start off with the epidural anesthesia with your painless labor dosage. So that will be very good for these things. Okay, fine. So positioning and marking, yes, everything it has already been told. For stenosis, you mark at the medial pedicle line. Why? Because you need to angulate it to go under the base of the spinous process to reach the other side, and this is only 15 degree angulation. And after you have marked it, you can instill a mixture of lignocaine, Sensorcaine with adrenaline. This gives you local pain relief also, plus a little blood hemostasis. So after that, you confirm your things under SIAM. Make sure you are on the lower border of the superior lamina, and then you start. So first, always you have the same working steps. Your nurse should not get confused, you should not get confused. So then if you have the same working steps, you will not miss any steps also. So what I have been doing is, I start the lower end of the superior lamina first. Once you start it, here you start it using an aggressive burr. Why do you use an aggressive burr here? Because we know that the flavum is in 2 layers, and the flavum gets attached to the under surface of the superior lamina a little more cranially. So you always have the flavum underneath. as a protective layer. To save time and to do it faster, you can use a aggressive burr there. Okay, but that is the different area there. Once you have finished the superficial sort of thinning out area, after that also please don't go there. Once you are there, for the finer work, change to a diamond burr. Once you have thinned out on all these things, and that is more safer because you don't know where the lamina is going to end. And once you have done with the diamond burr, sort of, it looks a little like glass, and all this phloem is nicely seen. Then what you can do is, you can use a curette to separate the phloem from the bone. I was not doing this earlier. Instead, I used to poke my kerisens into it, and I was a little scared to do it. This was taught to me by one of my Korean friends. So then, after I started doing this, use a curette, nicely make that cleavage ready, and then it makes it easier and safer for me to put the kerisens in and take it off. You can do this step also by burr completely, but it takes a little bit more time, and as you gain more experience, you get more impatient, and you want to finish off with hand instruments faster and better. So this is how you sort of dissect the interface. Once you have done through that, then your kerisens shall take over. Here in your kerisens, 4 mm big bites you can take and do the things faster. Once you have done there, so till what level you go? You go till the level where the phloem ends and the dura opens out. So that is the level of superior drilling or your detachment of the phloem. So if you have gone there, then you don't have to do any more work there. You recognize that by the ending of the phloem, it will end in a smooth line. You see a little bit of epidural bleed there, and you just follow it more laterally and also. Then you come to the inferior side. The superior end of the inferior lamina, it is always diamond burr. Why? Because the lamina is like this and the phloem attaches on top. It is attached only for 1 or 2 millimeters. So previously the phloem was under the lamina and for quite a distance, maybe 5-6 millimeters. Here in the inferior lamina, on the superior end, it is only 1 to 2 millimeters. So you cannot take a risk with your this thing. So always use a diamond burr. Same principles. Again, after you have cleared out all those areas, easily you will get the end of the lamina, end of the phloem. So take 2-3 bites and that's it. So once the superior end is exposed, inferior is end exposed, try as much as possible to finish all your work, bony work, before you touch the phloem, before even you want to expose and see the epidural space, because the phloem will act as a protector for your underneath neural elements. Do the contralateral access also first itself. Go to the base of the, go to the base of the spinous process, angulate your scope, turn your scope to the contralateral side, and then start burring the base of the spinous process. You can start off where you left in the superior end and then just go a little bit more medially. And then once you have done this job, use the same curette to sort of take it off something like a dosa or a chapati from underneath. It makes sense also because it easily loosens all your small fiber-like attachments which can distract you from both sides or from at least 3 sides once you have done it, and then you know that it has become loose. Earlier we were doing it piecemeal. Every time you take it piecemeal, it comes out like noodles and you waste more time there. So that is why it is preferable to dissect it en bloc. Once you have sort of removed it en bloc, or at least 75% of it en bloc, you can pick it up with your routine forceps, and most of the phloem comes out, except that in the lateral recess area will be very much attached there, and that will not come out that easily. That you will have to do with your routine kerisens. But by the time your plane is already exposed, so you know where to go and you know where not to go. So you just have to follow this thing. You have to find the lateral border of the dura. That till that level you have to expose. That will be your traversing route, and that will be a traversing route. And so you just have to see the lateral border, and you have done the job on the one side. So this we don't have to do it regularly. Once you know how much of the traversing route has to be exposed, you don't have to take radiological proofs. I have done this just to, for academic purposes. People will wonder till how long can you decompress. You see this. I can go below the inferior pedicle also. Very easy. Very easy. You can easily go. If you want to go superior, you can go till there, no issues. Okay. So finally, the contralateral side also you do the same thing, and you make sure like your other side is also completely exposed. So these are the few basic steps which we use. Here the main differences are the scope is different, the angle of vision is different. Do your bony work before you want to lift off or remove the flavum. The fourth thing is the scope or the sleeve does not go into the canal. In contrast to the interlaminar technique which Dr. Sai Dilip was telling about. This is how much you can see the contralateral also. Here you can do this procedure called annuloplasty also. In annuloplasty you put in a sleeve. Here in stenosis surgeries the annulus is intact, the disc is intact, and it is bulging. Once you have decompressed posteriorly, the nerve roots are completely free. You do not have to touch the disc or you do not have to damage the annulus. So what we can do is you do the shrinking. So once you start doing this procedure, the annulus sort of, dries out and becomes something like a leathery thing, and it shrinks in size. So this procedure is called annuloplasty. If you do this, this is more than enough. Unnecessarily, we don't have to go ahead and this thing. So one more time you just have to do it and see that is a traversing route, lateral border, everything, and then you can see go to the other side, all these areas are exposed. See, all these things you can do with 1 centimeter incision. You can put 1 stitch, you can put 2 stitches, everything. I have been taught by Professor Lim to put a drain always. I put a drain always, and then that is a post-op MRI you can get. From here to here, you can get it under half a sensory anesthesia, and the patient is mobilized immediately. They are given just a simple corset for 2 weeks, neurological assessment, they are discharged the next day. Thank you.